Okay. Right. Hello, my name is Abdullah Kassim, and I'm from Kent Medical School. So today I'm just presenting a clinical audit on liquid morphine or morphine sulphate prescriptions for chronic pain in a primary care setting. Right, so let's have a look a bit of the background. So opioids are analgesic drugs. They're recommended for mainly acute pain, so whether this includes after surgery or palliative care. However, they are not recommended for long-term therapy use, and that's against the NICE and the Faculty of Pain Medicine and Care Quality Commission. And additionally, we're seeing evidence where opioid use is insufficient for let's say, for chronic pain usage. And they show instead a high risk of dependence and addiction. And one may say that may be due to the failing of lowering such opioid doses. But despite these recommendations, we are seeing prescribing rates that contradict them instead. So I'll show you one graph example conducted here. If you have a look at the blue, and this is correlated to morphine, we're seeing a greater rise in morphine or mainly all opioid prescriptions over the years, and these are high dose prescriptions. This means over 120 milligrams. Additionally as well, this audit also looks specifically in liquid morphine sulfates, and the Faculty of Pain Medicine state that actually these drugs should actually be used for people who do have swallowing difficulties, and they show high misuse potential. So the idea of this audit is to look at the prescribing rates in one of the GP settings found in the Southeast. We're going to look at some of the challenges, have a discussion about why have these results presented in itself, and some possible interventions as well. So let's have a look at the methods. So this was conducted through EMIS at the GP practice, and we had a study population of 35. We had to cut down 7, so 5 of them were palliative care, 2 of them were prescribed within the 4-week period. So we want to look at those within after 4 weeks and 6 months. And I'll get to why is that later. We then had a look at the key parameters assessed, as such shown. So one of the guidelines stated by the Faculty of Pain Medicine is that once prescribed on opioids, they should be reviewed within the 4 weeks, and then they should be reviewed subsequently every 6 months. Additionally, a manual search had to be conducted whether someone had a swallowing difficulty or not. And this was either because they had a history of difficulty of swallowing and eating, whether they had speech and language therapy, any surgeries, any tumors, cancers found within the neck. And all of them was, all the methods on gathering the results was based on the NICE and CQC guidelines and Faculty of Pain Medicine. So based on the results we've gathered, most tend to be prescribed due to chronic pain. And for example, majority of them found to have fibromyalgia. Only 3 people were prescribed on the recommended, which is for breathlessness. Having a look at the reviews as well, those have been prescribed. Majority of them have not even been reviewed at all. Only 1 has been reviewed within the 4-week period. Some other results to look at as well. 36% of those who were prescribed oral morphine sulphate were on repeat prescription. Of the 23 that did not have an opioid review, a majority of them had a general medication review, which means opioids were not even part of the discussion at all. And 93% of them showed no swallowing difficulties. And we even had 1 patient that actually overdosed, and they were not reviewed at all, and they're still on repeat prescription. So having a look at the discussion side of it, we'll go by bullet points. So the first thing is that we're seeing that these opioid prescriptions, that majority of these patients are on repeat prescriptions, and this means that less reviews are going to be conducted. We could say that this could be due to the increase of e-prescribing within the UK. And the idea that it's easy to prescribe Oramorphine sulfate or any other drugs digitally, or if you're not face-to-face with that person. And another thing to highlight is that Oramorph is a Schedule 5 control drug. It's not a Schedule 2 drug, which means that they can be on repeat rather than acute prescriptions. Another study argues that opioid reviews, these medication reviews, well, the health practitioners say that they're too short. But on the flip side, the patients say that actually, if we were told about these risks of opioids, we would have stopped them long ago. And thus, it is important to highlight these 4-week periods or to do a review, because if it's not effective, it needs to be stopped. And lastly, Oramorph presents as a risk factor. Due to the fact that it's prescribed as a bottle, if a patient says, I have X amount of pain, I'm in so much pain, and they take a certain amount of volume of drug, this correlation of volume and pain is not a thing. However, they feel that if they can swig the bottle, they are less likely to feel any pain. And plus, it presents a risk of misuse. And this is really highlighted those who have mental health conditions, presents as a risk factor to self-harm or fatal overdose. So some interventions. First, though I hope in the future, to wean doses slowly, there is a necessity to change repeat prescriptions to acute prescriptions and to invite them for a review of such, whether that be online, text, or through a letter. Suppose they are reviewed, a reduction template should be offered between you, the healthcare practitioner, and the patient. And it should be something like reduction template, reducing our opioids together. And this is suggested by the Faculty of Pain Medicine, but it's not something that's actually implemented as such. And this helps that if this such template is more personal, it means that actually perhaps these patients will tackle the patient's fears of the pain returning or the chance of withdrawal due to dependence. And the last thing is to switch the oral morphine to extended release tablets, and which provides immediate release. And this means they take less doses to sustain pain control. So in conclusion, as you can see here, there is an urgent action to improve opioid prescribing. But one of the biggest things is, as the Dean said himself, we can do all these audits, but a research is needed to compare, and ideally to compare between the Southeast, the North, and London regions, because one study states that this opioid prescribing is geographically variant, and we need to see why is this as such the case. We've seen the opioid epidemic in the US, and it shouldn't repeat here in the UK either. So thank you very much.
That first graph that you showed us about the use of morphine or Oramorph, that was drastically increasing. It stops in 2016, and it seems that there was a decrease at the end.
Yes.
Why do you think that drop is, and how do you predict that the rest of the graph has gone up until 2025?
Great question. So this is actually one of the latest data on the opioid, opioid rates of prescriptions within the UK. Interestingly, the study actually didn't talk much about this dip at all, which I find shocking myself. So I did realistically take it up to 2015. So apologies, I can't answer the question. Yes.
Thank you. I enjoyed that. I suspect in doing the audit, you've been extremely frustrated now, and you've got lots of research questions. So what research questions might have generated for you, and what methods might you want to employ to answer them?
I think my main, as you know, the overdose was shocking to me. I think I want to understand, mainly the idea is, as a healthcare sector, because I sit in within GPs, I do ask them, why do you just put a repeat prescription? Why do you prescribe for even if you know it's not going to benefit them? And they'll say things to me such as, it's because I don't want to fight back with the patient, it's too much of a hassle. And I want to see, is this that's shared among everybody else? Is this something that everybody agrees with, or is this just that one GP? So I want to tackle that kind of behavior of how can we stop opioid reduction mainly within that primary care setting rather than higher up, because if it doesn't work, if they're stopped at and the additional thing is, even if they're stopped at primary, they'll go to secondary, they'll then go to a specialist, and then that just goes right back to primary. So there is a lot I want to explore, so not just a primary setting as well. Thank you.
Thank you.
Oh, yes.
Sorry. So you talked about how there is the drop-off on the follow-up rates and how they're not really getting a follow-up appointment. You talked a bit about the e-prescription could fall into that. If you had any other ideas as why these patients aren't getting a follow-up with their morphine use?
So one of them was that the time of the what's it called, of the medication review. So interestingly, that in that GP practice, all medication reviews are done within one kind of setting. So the idea that if they've got hypertension, that drug will be reviewed, and opioids fall under that. Interestingly enough, opioids rarely get touched at all. It's mainly the drugs that I talked about. So it would be nice to know that whether opioid reviews can be done as a separate thing rather than for something that's combined. I hope that answers your question.
Thank you.
Thank you.
Thank you very much.
Thank you.